Yep.
Right?
Looks great.
So, docs, our partners, our leader doctors, thank you for making the time to be with us tonight. This is very exciting, as we discussed yesterday on our partners call. This is our launch of this partnership with 3DDX. I've known the founder of 3DDX for over 12 years. He's a dear friend of mine. Him and I have been talking forever on how we can work together, and I can't believe the day has come, and we already started our partnership here. Dr.Shadi Hassan has been with 3DX since 2015. He's a treatment plan consultant and team leader. Great wealth of knowledge when it comes to implant dentistry, treatment planning, implant dentistry. He's going to share with us a lot of pearls about surgical guides and implant case planning. And also he's going to explain to us how our partnership with 3DDX, basically how it's going to be streamlined and how we can submit cases. 3DDX is one of the premier companies with the best outcomes when it comes to surgical guides and treatment planning. He's going to share with us all the tips and tricks on how to connect with their team of clinicians to help us plan surgical guides in our implant cases, or maybe just as simple as, submitting the records and starting your cases. Without any further ado, Dr. Hassan, please share with us all what you got here.
Will do. Thank you, Dr. Barakat, for the introduction. Hello, everyone. How are you doing today? I'm very excited. And we here at 3 Diagnostics are all also very excited for the partnership that we have right now with Guardian. And this is going to be one of the first presentations that in a series of many moving on. And today we're going to be talking about introduction to surgical guides and implant planning using treatment planning softwares. So today's topics are going to be, first, we're going to be talking about the definition of computer-guided surgery, advantages of computer-guided surgery, how to acquire the data that we need, and we're going to walk through, of course, workflow, what we usually ask, and once we've got everything, how long does it take to have the surgical guide in your office, and we're going to talk about these details, of course, as we move along the presentation. And then we're going to talk in more details about the types of surgical guide you can be provided with and how to use them. And then, of course, we're going to be talking about the principles of treatment planning, what we usually do as dentists here in 3 Diagnostics, and how we can share our knowledge to help you with planning your cases. And finally, we're going to be talking about some challenges that we usually face with submitting records or DICOMs or intraoral scans, and how to actually avoid these challenges. So we're going to be starting with the definition, and I just would like to say that we're going to be stopping or pausing every now and then just to take your questions. If you have any questions, please feel free to use the Q&A box down below. We're going to try to pause as much as we can to answer all the questions. So with that being said, the definition of computer-guided surgery, basically it's represent a surgical concept and set of methods that use computer-guided technology to try to implement what we know as dentists in this treatment planning software that we use, and finally just end up with something that would help us and guide us in performing that surgical intervention. So right now we're going to be talking about the advantages, and most of you, of course, know the advantages of computer-guided, but we're just going to talk about each one and try to explain as much as we can, of course, with what we always aim to do here in 3 Diagnostics with computer guided. So the first thing and most important, of course, is that we always have a prosthetic driven approach. And this helps us a lot in placing implants, making sure the final outcome and the prosthetic is going to be an advantage in the final product, and just to prevent any concerns or any problems with the future prosthetic. So here's an example on the left-hand side. We've got a screenshot of an implant that was placed in a DICOM or just patient scan. And usually when we have the patient scan imported, what we sometimes always look for is good bone support. So this is an example of a cross-sectional cut in a patient's mandibular arch and placed an implant. So here, without any records, you can see that the implant looks good, looks fine. We've got plenty of bone support on both the buccal and the lingual surfaces. But when we actually import the patient's records, as you can see here, we've got the intraoral scan or impression of the arch of interest. We've got the opposing dentition and the relationship between them. We were able to have a virtual wax-up placed. So just to see the anticipated prosthesis that we're going to end up having. And using the same implant position, you'll notice that the emergence of that implant is too lingual. So this would end up having a huge cantilever on the buccal, which would be, of course, destructive in that for that implant moving on. So this is why it's really important to have records before we plan our case. And this is also something that we actually recommend to send before we plan a case or finalize. So this here on the right-hand side is the same cross-sectional cut. The only difference is we've utilized or used those records and the virtual wax-up to correct the orientation or angle of that implant to have it in a screw-tamed position and have it planned in a way to have the implant perpendicular or just emerging towards the functional cusp of the opposing dentition to have axial forces falling on that implant, which is, of course, the forces that we're looking for. So no non-axial forces should be considered destructive. So this is just an example of how we use the records, which are the DICOMs and the patient's bite and impressions, to be able to have a product in the end that's going to be what we're basically looking for. So to prevent any complications in the future. So the second advantage is precise implant placement. So here, those are a couple of screenshots that we've taken. So those are post-op scans. And what we did is we overlaid the pre-op scans with the virtual implants in the planning software, and we stitched them together with the post-op. And as you can see through these screenshots, the red outline, which is the implant that we planned, is pretty much just lined up with the implant that ended up in the bone. So this is just an example of how computer-guided surgery helps a lot with accuracy and placing the implant in an anticipated position. So this is also one of the advantages of computer-guided surgery. And then, of course, one of the most important advantages as well is to have an easy flapless surgical approach. It's easier for you, easier for the patient, always better for the healing as well. So guided surgery can help you with that. And again, one of the most important things when we plan for a flapless procedure is it depends on the position of the implant you're placing. So if it's far back in the molar sites, we usually tend to have the axis better. So sometimes it could be a challenge, but as long as everything is fine, the patient has good mouth opening, we can actually plan on having a flapless procedure, which would finally provide you with less chairside time. You can execute a single implant in less than 30 minutes. So that's an advantage. Of course, you can actually use your time in using or having multiple procedures done on the same day. And then it also minimizes the surgical complications. So here we're going to find two screenshots, one on the left and one on the right. Those are examples of implants that ended up in unfavorable positions without using the guidance of the templates that we provide. So you can see that sometimes, even though we do have the experience, sometimes we end up having the implant either perforate the lingual plate, or the implant, just because of the density of the bone, sometimes would sink and would injure the nerve. So guided surgery would prevent having those complications. And then it's less discomfort, as mentioned. It's better healing for the patient. Here's a picture of the tissue healing well in a flapless procedure. You can place a healing cap on top of that implant and end up having a good emergence or good tissue profile. And finally, of course, understanding the treatment plan options and explaining to the patient what those options are. So you can actually share those treatment options with the patient and have the patient decide whether they want to go with one of the plans or the other. So it's just really beneficial in terms of explaining to the patient the types of procedure that they could have. So those are the advantages. One more thing is prefabricating prosthetics. And this is something that we as 3D Diagnostics can help you with. So when you submit a case, and once we were done finalizing it, Sometimes we actually also could have a consultation session online, so just to discuss the options we've got. But if you want to have the patient walk out of the office with a prosthesis, we can actually provide you with that. So it's going to be a surgical guide that's going to help you with placing the implant, and finally a guided prosthetic that is either for a single implant or for a full arch. So we can provide you with a PMMA or temporary prosthesis that can actually load at the same day, and everything is going to be guided. I think this is actually one of the good things that we can have with guided surgery, because the patients actually are expecting that, to just go in, get the implants placed, and then walk out with at least something that would just restore function and aesthetics. So this is something that we can provide you with, of course, with the cases that you submit. So what are usually the data we look for, or the records?
Doc, do you mind if I stop you for one
Sure,
second?
go ahead. Of course.
I want to make sure if anybody has a question. I do have a couple of questions, but I want to open up the floor if you don't mind. Do you guys have any questions about the advantages, any of the stuff that were discussed, the 8 points? Let me see. You can raise your hand, or you can put the question in, or if you have access, you can actually ask. I do have a question actually myself. If you don't mind going back to the flapless surgery part.
Okay. Here.
So I would like to pick everybody's brain just very quickly and briefly on what do you guys typically do when you're doing surgical guides or flapless? Do you always do a flapless technique, or do you flap? What do you do on the anteriors? What do you use for making it flapless? Do you use tissue punches? Do you use lasers? What do you guys do?
Oh, so
Dr.
basic.
Grimes, yeah.
Yeah, so someone here is
Dr. Grimes, yeah. Dr. Grimes, can you are you able to unmute and talk, or we didn't give you access?
I don't think he has access to the, no.
I said all panelists. We might need your team's help to allow everybody to talk, maybe.
Okay, let me check.
Do you mind typing your question, Doc, until we get this sorted out? So Dr. Van Sluten, no, that was before that we started. So Dr. Hassan, what do you think?
Well, usually what we recommend is, as long as we've got the metal sleeve in the surgical guide above the tissue, then they can simply just place the guide on top of the teeth and just remove that tissue with a punch. And of course, you can have that done guided through the sleeve. So it's as simple as placing the tissue punch inside, scoring the, or just cutting the tissue and take it out. So, yeah.
How about anterior cases where the tissue is so important? What do you guys typically recommend?
Well, we always just recommend, or actually move towards having a flapless procedure, because it's always easier for the patient, always easier for the clinician, and especially in the aesthetic zone. So we try our best, of course, to keep the sleeve without a contact between it and the tissue, to have that flapless procedure done. So again, same concept. Once we've got the sleeve completely within the tissue, then we recommend using a tissue punch through the sleeve, take out the tissue, and drill the osteotomy.
Okay. I would love to get some, but we have some great clinicians here participating, so their thoughts would be awesome to share. So Dr. Grimes is asking, 3DVX has usually provided guidance regarding whether it needs to be flapped. I've always used a punch. Only problem I have run into with flapless is the bony contour. So Dr. Grimes obviously has used your company before, and you guys usually make recommendations, right?
Of course, we do. But I think what he's saying right here is sometimes we place the implants a bit deeper, and sometimes we would need to do some plasty or just crestal bone profiling. So, and that could be difficult through a punch, basically. So what we usually recommend. Sometimes the site needs to be flattened. Exactly. So the reason why we recommend flattening the site before placing the implant or just after placing the implant is if the implant is too deep in the bone because of either a defect present or and this is the way there's some vertical bone loss on one of the sides, then we recommend flattening the bone because it's going to be easier to place the abutment in, because sometimes the abutment binds up with bone mesiodistally or, for example, on the buccal or the lingual if there's vertical bone loss on one of the sides. So yeah, that is a recommendation. It might be difficult to do it through a punch. So most of the recommendation will be opening a crestal incision. So it's not going to be with a vertical releasing incision. It's just going to be a crestal incision that you can have access to wedging the tissue, removing that part of the bone, and then suturing.
Awesome. Sorry to interrupt you, but I think we're going to try to gather the questions, and maybe every time we stop, I'll try to run the questions by you.
Okay, someone's saying that the chat is disabled. Let me check if it is.
Yeah, so Dean is checking to see if there's a way to allow attendees to speak. I think the way that it was set up initially, it's best to go ahead and put the questions in the Q&A for now, and then we'll see if it's possible. Thanks so much.
We can have that, yeah, further discussion towards the end.
Okay.
Awesome. Thank you.
Okay, let's move on to the part of the records we usually ask for. So goes without saying, of course, we would need a cone beam CT scan, but it would depend. The rest of the records, of course, we usually ask for would depend on the situation, of course. So sometimes a patient would come in with a full set of teeth, or a patient is partially edentulous, and sometimes they come in completely edentulous. So in the first scenario where the patient has dentition, then of course it would be a cone beam CT scan. And we recommend sending us, of course, an intraoral scan of the arch of interest. So usually the arch of interest would only be enough, but I think it's just more ideal, since we've seen in the previous example, to send in the opposing and the bite, because it helps a lot with setting the virtual wax up, seeing the patient has any problems with bite, or maybe just, for example, a cross bite or an open bite. So it helps a lot in identifying the patient's articulation, or just patient's bite, basically, and that will give us more or just better example on how to plan and execute the case. So as mentioned in the first scenario, cone beam CT scan, intraoral scan. If not available in your office, if you don't have an intraoral scanner, then what you can do is you can take an impression, either pour the impression and send us the model, or just send us the impression, as long as the impression is taken with PVS. So we're gonna be talking about that in the next slide. And right now we're gonna move on or shift towards the other scenario where the patient is completely edentulous. So the only difference here is the way that you're gonna be scanning the patient. So again, you're gonna also just need to send us a cone beam CT scan. The difference is, if the patient has an existing denture, what you can do is you can scan the patient with that denture using a dual scan protocol. So we would instruct, of course, on placing radiopaque markers on the polished surface of that denture, buccally, or on or on the lingual or palatal surfaces. And then you would place at least 4 to 6 on the buccal and 4 to 6 on the lingual. And before you make sure that you send or just scan the patient, make sure that that denture is relined. And we're going to also talk about that in more detail moving on. But again, the difference is that you take the scan with the patient wearing the appliance, and then you take out the appliance and scan it alone. So you're going to have 2 sets of DICOMs sent, and with those 2 sets of DICOMs, we're going to be able to stitch them together. And I'm going to show you how we do it right now. So this is just the first records, of course, the cone beam CT scan DICOMs, and send us those DICOMs. And we have some recommendations when you scan the patient. So either the patient is edentulous or has dentition. There are some recommendations that we actually we actually provide you with before you scan the patient, just to prevent having any challenges with using those records. So the first thing is a cone beam CT scan, not a conventional CT scan, although it does work, but a cone beam CT scanner gives you more resolution, and we recommend a slice thickness of 0.4 to 0.5 millimeters. And then another thing we recommend is making sure the patient does not move, because if the patient moves while scanning, that is going to generate a mirror image. So it's going to make it really difficult to identify the patient's anatomy. The occlusal surface of the arch of interest has to be horizontal. So basically, or cone beam machines have ways that can orient the patient's skull before scanning, because that's going to help us a lot with the design later on, and making sure the design is going to work on that coordinate, or the patient's coordinates, basically. And the field of view must cover the arch of interest and at least 5 millimeters of the opposing. The reason why we recommend, of course, scanning the opposing, because in case that you send us records without the opposing dentition or the opposing model and the bite, sometimes we can actually use the patient's dentition, or at least what is appearing of the opposing dentition, to identify what type of occlusion the patient has. And that also helps us a lot with the planning. Make sure the patient's teeth are separated. So we recommend having the patient bite on cotton rolls. The reason why it's really important, because when it comes to designing the surgical guide and matching the patient's intraoral scan or impression to the patient's cone beam, it's really important to see the occlusal anatomy of that patient's dentition. So when the patient's biting down and there's no separation, sometimes we find it really difficult to separate the arches from each other and seeing that occlusal anatomy. So it make it more difficult in stitching the patient's intraoral scan to the cone beam. And finally, separating the lips and the cheeks from the gingiva, and that is done by either placing cotton rolls in the vestibules, buccally and labially, or having the patient just bite down on a tongue depressor and blow just to separate the lips and the cheeks. And also the reason why it's really important is because if the dentition are not really clear, if there's a lot of metal framework or just metal restorations, sometimes we have artifacts. So the soft tissue or the shadow of the soft tissue would help us to match also the patient's intraoral scan with the cone beam. So those are the recommendations. And here's an example of, or screenshots of, a patient here being scanned with cotton rolls. And as you can see right here, we have the separation between the lips and the facial tissue, and the same thing on the opposing. And this is a look at it from the axial view. So you can see also here, this is the shadow of the tissue, which will also help with the merging of the patient's intraoral scan to the patient's dentition or the patient's cone beam. So we've mentioned before, again, when a patient is dentulous, you need to have an impression or intraoral scan. The thing that we recommend, of course, is when you take an impression, it needs to be PVS impression and not an alternate impression. The reason why is that PVS is more dimensionally stable. So what you can do is you can actually report again, or just once you've taken the impression, you can just send it out and then we can port in the office. So it's just more reliable and does not show these discrepancies with the setting of the model, because with the exothermic reaction, of course, of the model setting, there will be some shrinkage if you use alternate. And the records, of course, must represent the patient's hard and soft tissue anatomy at the time of the surgery. So that's also one thing that is really important, is if the patient is going to have any crown work done, you need to make sure that you wait until the crowns or whatever the restoration is done. Then you take that impression, because that's going to represent the recent anatomy for that patient. And when we have a guide processed, we make sure, of course, that the patient or the guide is going to see it on the existing anatomy. So here is an example of challenges we have with the impressions and intraoral scans. We're going to be starting with the first one on the left side. Right here, we have an implant that's going to be placed at number 31. The problem here is that the intraoral scan did not extend distal enough to cover the distal tissue. The problem with this scenario is that we're not going to have enough acrylic support around the metal sleeve when it comes time to process or design the surgical guide. So one of the most important things when you take an intraoral scan or an impression, especially for edentulous sites, you need to make sure that the impression or intraoral scan represents the tissue as far distal as possible. So we have that representation of the soft tissue, and we can design the guide without any flaws in the acrylic support. And so this is why it's really important. The second image right here, this shows an impression that is distorted. Whenever we receive an impression like that, it's just going to be really difficult to pour. So sometimes it's not accepted. And even if we try to pour a model, it's not going to be accurate enough to match with the patient's anatomy. And finally, the one on the right side here, if you're using an intraoral scanner, you need to make sure that you move slowly while just recording the images, because if you move too fast, then there's going to be some problems with the stitching, and you'll end up with a void or a gap, as you can see. And this right here is going to be a problem because this here is a tooth distal to the edentulous site. So we're not really sure how wide the restorative space is. So that's going to be a problem with designing the virtual crown. Another thing is if the sleeve is too close to this part of the tooth, that we're not going to be able to judge whether it's going to be hitting it or not. So again, move slowly while recording the records or taking the images, just to make sure that we don't have any problems with the stitching of those images together. So once we've got the patient's intraoral scan or a model or an impression, we have the feature here in the software that we use is to import that impression or model and try to match these dentition or the occlusal anatomy, as mentioned before, with the occlusal anatomy of the patient scan, which is on the left side right here. So we have a segmentation done of the patient's arch, and then we match the dentition with the dentition on the impression or intraoral scan. And this would be the result. You can see that this orange line, this is actually a cross-sectional cut in the impression. And you can also see the anatomy of the tooth right here in the scan. And since the patient was not scanned with the lips being separated, you can see that the shadow of the tissue is not really clear here. But as long as the tooth is clear, the scan is does not have any artifacts or any problems, we can just match the cusp tips, for example, together in the cross section. And we use point registration, so multiple points on both sides, just to make sure that both sides match fine. And once we've got a good match, we can then use that match or use the SDL to design a surgical guide. So right now we've talked about the patient being having dentition. Right now we're going to move on to an edentulous patient, where we said we're going to take a scan, but in a different approach. It's called a dual scan. So basically, a dual scan is whether the patient has a denture or does not. You would actually have or fabricate a temporary denture for this patient. You need to make sure that it does not have any metal, because metal would just generate a lot of artifacts. So it's just completely acrylic, or just complete acrylic. And even if the patient has the denture already existing, you need to make sure that the denture is seated well and adapted well in the soft tissue, and there's no gaps between the intaglio of that denture and the soft tissue. So once you've made sure, you're going to get those radiapic markers, which we can also provide you with, and they're basically stuck on the denture. So you can see this image on the left side. You use these markers to stick them on the lingual side, and we recommend 4 to 6 markers on the lingual side and 4 to 6 on the buccal side as well. And then once you've set all these markers in positions, you place the appliance back in the patient's mouth. You have the patient bite down on cotton rolls, and you scan the patient with that appliance. Okay, so if the patient has an existing denture, you, again, as mentioned, you need to make sure it's relined. So we recommend relining the denture with a soft reliner that is radiolucent and not radiopaque, because if you use a reliner that has radiopacity to it, it would generate a lot of artifacts, and it's just going to make it difficult to see the anatomy, especially the soft tissue anatomy in the scan. And then once we've got the patient scan, we take out the denture, scan the denture alone, and make sure that the position of the radiapic markers are exactly where they are. And then we take those 2 DICOMs and we stitch them together. And as you can see in those pictures, we've got the radiapic marker in the scan. You can see it very clearly here. And then you can see that this is the outline of that radiapic marker. So we use those markers as reference to match them from the patient's denture to the scan. And this is also another cut or another view where you can see the bulging of the markers here and the radiopacity of those markers as well. And once we've got everything set, here is the final outcome. So once we're done stitching, you can actually see the patient's denture right now. You can see the flanges, and you can use those dentition on that denture. So you can use them for planning, basically. So we're done with this part. Do we have any questions, Dr. Barakat? Would you like to add anything?
I'm hoping that we were able to open up the mics maybe for the attendees so they can ask.
Sure.
If not, if you
Dino is checking on that. Yeah.
Yeah, so with the platform that we have, because we never know the number of attendees, it's not able to open up the microphone, but they can type in the questions in the Q&A spot, which we have another question that's come in from Dr. Grimes here. And do you want me to read the question, or did you want to do that, Dr. Barakat?
Yeah, I'll read it. So Dr. Grimes was
sure.
asking, irrigation is restricted with surgical guides, with most osteotomy burrs not being internally irrigated. What do we do to keep the bone from overheating during preparation of the implant site?
Okay, so basically sometimes what we do is we create a window on the lingual side to make it easier, so you can actually just introduce the irrigant while drilling the osteotomy. And this is something that we're actually, we've also worked on something else to have like a path or just like a tunnel on the lingual side of the guide, where you can actually just with a syringe, of course, you can just irrigate.
Yeah,
exactly. But usually what I would recommend is, of course, not drilling just with you need to make sure that it's intermittent, of course, so you don't actually have a continuous flow when you drill the osteotomy, just to make sure you don't have any overheating, which of course would affect the implant's integration. And again, sometimes also we just create that window on the lingual side, just so you can introduce the irrigant without any problems, and that would fall into the osteotomy while drilling it with the drills.
Yeah, and that's a great trick. Dr. Grimes, does this answer your question? Any other questions from anybody else? I think we're good. Dr. Grimes was asking, does PVS impression material work for the RELINE?
It would, but the problem is that PVS is radio opaque. Sometimes the radiopacity is too much, so we're not going to be able to use that when we do the stitching of the patient's denture to the scan. So I wouldn't recommend PVS impression to reline the denture.
Okay. A RELINE material, I think, is
exactly
radiolucent. Yeah, a soft RELINE material.
Yeah.
Great. I'll gather the questions and I'll share them with you as we go.
Okay, sounds good. So let's move on.
Yep.
So what are the types of the surgical guides we have to offer? So I've divided them into support and guidance. So let's talk about support first. So we've got 3 types of surgical guides: teeth supported, tissue supported, and bone. And then we're going to talk about the guidance. We've got partially guided and fully guided. So teeth supported guides, this is how they look like. So on the right side, this is a virtual design of the guide. You can see that right here, we have the acrylic support rest on the teeth. So the entire support is going to be from the teeth and nothing else but the teeth. And on the left side, this is how the surgical guide is going to end up being after printing it. And then once we've got the surgical guide printed, we glue in the sleeve and then make sure it's seated on the patient's model well before sending it and making sure it passes QC, and then we send it to you. So this is, I would say, the most accurate guide of them all, because you have a lot of undercuts and it's basically just resting on the occlusal anatomy of the teeth, and part of it is on the buccal and the lingual as well. So with engaging those undercuts, that would be considered the best kind of support for a surgical guide. The next guide is a tissue supported, and this is on the right side. This is the design, and this is actually the patient's denture. So what we did is we took the denture and we processed, or we designed the guide to be a replica of that denture, So right here, this is where the dentition would be basically, but since we've got those guiding sleeves, we had to just create a flat surface for those sleeves. So when you go in, you need to make sure the kit or the drills you use have the physical stoppers hit the top of the sleeve. So, but it's just going to have the same fit of the denture. So this is why I've mentioned before that it's really important to make sure that the denture is seated well in the tissue, because in the end, the surgical guide is going to have the same seating or the same intaglio as the denture. And this is how it looks like after printing it, of course. And those extensions on the buccal surface, those would be the sleeves for the fixation pins. So this is an extra mean of retention. As you all know, the tissue is, there's no undercuts. Sometimes you would rotate the guide. So you need to make sure that the guide is just stabilized by those fixation pins. We get the anchorage from the bone, of course. And once you have those pins placed in, you then use the guide without any problems. And finally, this is the bone supported guide. So we've got two types of bone supported. We've got the conventional bone supported guide on the left side right here. So this would have an intaglio that would seat or rest on the alveolar crest, and then also fixation pins on the buccal so you can fixate it in. And another type of bone supported guides would be the bone reduction. So this is actually a picture of our new guide design. Right now we're using the magnets, of course, to stabilize the guides on top of each other. So this is going to be the foundation. You're going to place it in and drill the osteotomies of the pin, stabilize the guide with the pins, of course. And we've designed it in a way to avoid having any flange on lingual or palatal surfaces, because it's a lot easier not to reflect the tissue, especially in the maxilla, where you've got thick keratinized tissue. So this would make it easier to have the guide seated without extending the flap too much. And once you've seated the guide, you use this platform right here to level the bone to be parallel to this, or just at the same level of this platform. Now we're going to talk about the guidance. So we've got two types of surgical guides. We have a partially guided surgical template and a fully guided template. So partially guided meaning that it's not going to provide you with all the guidance. So it could provide you with only depth, angulation, but you're not going to have sequential drilling. Or even if you have sequential drilling, you're not going to have implant placement control. So partially guided does not necessarily mean it has to be a pilot guide, but it's just a surgical template that would provide you with certain guidance, but it's missing one of them. So it's either sequential drilling, depth control, or implant placement in the end. So this is just an example that it could be just a pilot guide where you use the pilot or initial osteotomy or initial drill to drill the osteotomy and then remove the guide and continue freehand. And then the fully guided would be the opposite, of course. So everything all from A to Z would be guided. You're going to seat the guide, drill the osteotomies through the metal sleeves, and then finally place the implants through those metal sleeves. So even the insertion of the implants and the timing of the connection would be guided. So right here, as you can see, we've got those green notches or grooves on the guide, which would guide you to where to stop the timing of the implant. So just to have the internal connection, of course, set in a way that when you place in the prosthetic and the abutment, of course, it's going to be lined up perfectly the way we planned it. So this is the definition of fully guided. And that also is another picture of the drilling guide placed on top of the bone reduction. So in this scenario, you're going to be placing the bone reduction in first, reducing the bone, and then once you've done that, you're going to just have the drilling guide stacked on top of it using those magnets, and then drilling the osteotomies and placing the implants in. So we've talked about the fixation pins. On the right-hand side, you've got a picture of where usually we would use the fixation pins or positions and in which scenarios. So in patients that are dentulous, you use them mainly in edentulous spaces, just like that here in a freehand saddle, because we're lacking distal support. So we want to make sure the guide does not flex or rotate. So usually we place a fixation pin here, or in cases where we have a long span between the support. So here we've got a canine and a molar. So this is a long span, and that would also prevent having the guide flex. And of course, with the flexing, you know, maybe just have the osteotomies a bit deeper, and you've got the sinus and stuff. So you need to make sure that everything is just support it fine, and the fixation pin is just going to ensure that. And of course, on the bottom here, those are examples of tissue-supported and bone-supported guides. We're always going to have to use fixation pins in those two types of surgical guides. And we would recommend at least 4 fixation pins to be evenly distributed. And that is just to make sure that the guide is seated all the way from left to right side. So any questions so far?
So far, we're good. So far, we're good.
Okay. So principles of implant treatment planning. We're going to be talking about usually what we would recommend. So we're a company that's been providing dental digital support from, so we started in 2005, and we have a team of experienced dentists here that will help you with the planning. So what we would do or would recommend is an online consultation session where we can help you with either just deciding the type of prosthesis you're going to be using or restoring the arch with, and help you with placing those implants. So one of the things also we would help you with is to decide whether this patient is a good candidate for implant placement or implant procedure or not. And this is why I placed or just added this slide. So case selection is really important. What I would recommend is before you send in a scan is make sure that, first of all, this patient is a candidate for implant placement. We're going to be talking about the stuff you should put into consideration before you decide to have the procedure done. So case selection is really important. We're going to be starting with occlusion and forces, and we need to understand, of course, the type of occlusion the patient has and the forces. And here's an example of the curves of Spee and Wilson. So for example, on the left-hand side, what we did when we planned, we had a dentulous space from the first bicuspid all the way to the second molar. So we need to make sure we follow that curve just to make sure that the final product is not going to be destructive for those implants, and to finally just have something that is going to be functional without any problems. And then on the right side here is also another curve of Wilson. So this is, we're going to go through this together. We're going to be adjusting or having the wax up done online in an online session where we share our screens with you. And if we have any concerns, any comments, of course, we'd let you know then, so we can decide what we can do and how to work around the concern. And one of the most important things is mouth opening, and especially for implant sites far back in the premolars or the molar sites. Here is a picture of how to actually just measure the patient's mouth opening. So either, of course, with a ruler on the left side or with a 3-finger technique on the right side. And you need to make sure that the patient can open up wide enough, at least 52 millimeters. And the reason why this is important is we've seen a lot of cases where we planned an implant in the first or second molar site, or sometimes the bicuspid, and patients have limited mouth opening. And with guided surgery especially, this is going to be a bit difficult, because when you seat the guide in and try to place in a drill handle or a drill that is going to be, let's say, 15 to 20 millimeters long, if it's that far back, you're never going to be able to just drill or access the site with the drill if the patient has a limited mouth opening. So this is really important information before going in and deciding to place an implant there, because if you know that information, we can actually work around it. So either just try to place a shorter implant, use shorter drills, or lower the sleeve as close to the tissue as possible, so to avoid having this complication at the time of surgery. For aesthetic design, this is also one of the most important things. We've mentioned that before. So if you don't actually know what type of prosthesis you're going to be restoring the arch with, we can help you with that. And it depends on whether we're going to be restoring a fixed prosthesis or a removal prosthesis. And this is just an example of an implant that is going to be restored with either EP1, 2, or 3. And here also is another example of a full arch rehabilitation with either a fixed prosthesis on the left side or removable. So we have different indications, different criteria of the way of planning, and that could be all discussed in our sessions or the consultation session. If it's just as simple as one implant, we don't actually recommend having the session. What you can do is you can submit your case you can just let us know what exactly you're planning to do, the implant you're planning on placing, the surgical kit you're going to be using, and we can go ahead and plan it, send you an email with the proposed plan, and then you can approve it. And usually the guide would take 3 to 5 business days to have the guide in your office. So if it's a simple case, straightforward, you don't need to have that session. But if it's a complicated one, more complex, where you can actually place multiple implants, then we can have that session just to make sure everything is accurate, make sure everything is finalized the way that it should. And we can, again, process and have the guide in your office in 3 to 5 business days. So another thing you need to put into consideration is the restorative space. And we're going to talk about the vertical restorative space and the mesiodistal restorative space. So on the left-hand side, this is an example of an edentulous or in a missing tooth that we placed in the virtual wax up. And the help of the opposing and the bite, it just actually gave us here the means to just measure the inter-arch space. And you can see that, especially on the distal, we've got around 1.5 millimeters of inter-arch space. So the problem here would be knowing that the patient has a deep bite, or maybe just a supereruption of the opposing. And it will help you decide what type also of crown you're going to be restoring the site with. So if you've got at least 5 millimeters, then I would know that I could restore this with a screw retained. But if I'm planning on restoring this with a cement retained prosthesis, then I would need at least 8 millimeters of restorative height. So knowing that, of course, or just measuring that with the opposing, that would actually dictate what type of prosthesis or crown you could restore the arch with. Or we can actually know that we have a problem, and then we can actually have the solution for that problem. So either crowning the opposing or opening the bite. So that helps with the planning part. And this is why I always recommend sending the bite and the opposing. Another example on the right side, this is a missing molar that looks like has been missing for a long time. So the tooth distal to it, the second molar has mesially drifted, and you can see that closes up the mesiodistal restorative space. So one, you're going to have a problem with the emergence. Two, you're going to have this deep undercut right here on the mesial part of this molar, and that is going to act as a food trap. So this is actually also one of the things that we notice when we place or plan an implant. And then what we can do also is, once we've got the patient's records, sometimes it could be really difficult to place a sleeve that, let's say, for example, is 5 or 6 millimeters wide. Because if it's that wide and there's too much drifting of the molar, and the restorative space is less than 5 millimeters, then the sleeve, the metal sleeves would have some contact with the mesial crown of number 31 here, and the bicuspid. So it's going to be difficult to see the guide in unless you just get rid of that contact or that interference. So it's, again, we all this stuff we put into consideration, and we find out when we plan a case. So we always look for any concerns, any problems, just to make sure that we have an anticipated procedure, and make sure it's as easy as placing the guide, drilling the osteotomy, and placing the implant. Okay, so evaluation of vital structures. We all know, of course, the vital structures we have in the maxilla. So the sinus, the nasal cavity, and the nasopalatine canal. For the mandible, the inferior alveolar canal, the mandibular incisive canal, and the lingual artery. So this is, again, something we always take into consideration when we plan, especially for molar sites, where we want to make sure that the implant's not too close to the nerve. So what we're going to talk about right now is the anatomical variations. So we've talked about the normal vital structures, but sometimes what we do is we find out that the patient might have an abnormal or just a variation in their scan. So for example, here the patient has a type 2 canal. So it helps a lot when we take a look at this before we place in the implant, when we map the nerve, because it will give us at least an example of if it's going to be difficult to place the implant, if it's just not going to be in the way, for example, a bicuspid. So this is something that we always look for if we have any variations. And if we move on to the upper arch, we have also a variation on the top, which is called the CANALIS SINUOSUS or SINUOSUS. So this is just basically a neurovascular canal that extends from the infraorbital to, or just extends medially to the canine region or the lateral incisor region. And it's just really prominent. Sometimes it's just misdiagnosed with a blood vessel or the nasopatine. So with the experience, of course, of planning and looking at hundreds of thousands of scans, we would actually know the difference between a blood vessel and a canal stenosis. So this is one of the things we usually would just look for and try to avoid. So bone quality and quantity. So this is here a table just showing the difference in densities. We have D1, D2, D3, and D4. This is just a description of how the bone looks like. And on the right side, this is the Hounslow units of the density of that bone. So this is just an indication or an example of how to just identify whether this bone in the scan is D1 or D3 or D4. So this is basically how they would look like. So D1 would have a cortical outline and cancellous bone in the center. And then as you move along the density, or just if the bone is softer, then this cortical outline will be thinner all the way to this cross-sectional cut where the cortical bone is just really thin or actually sometimes absent. You have wide bone marrow spaces. So what you should also just look for is the density of the bone, and that is going to give you an example of how the procedure could be done. So whether you need to just do some bone expansion or densification or underprep osteotomy. So give you an example of how the bone would look like using the software before you go in and do it physically or clinically. And this is an example. Those are the screenshots taken from the software. You can see here that we've used the tool to measure the density in the maxilla and the mandible, just to measure the Hounslow units. And even though this is not 100% accurate, but at least it will give you an indication to whether this bone is soft or dense, or if we need to maybe just have an extra procedure done, or maybe skip the last drill, for example. And then we're going to talk about the quality. So it depends on the site, depends on the arch restoring, and depends from patient to patient. This classification is according to Dr. Mish. So we've got A, abundant bone. You can see here on the left side, we've got good height and good width. And then B, you've got barely sufficient, where you have either discrepancies in the width or the length or the height of the bone. And then compromise, where the bone is just really compromised vertically and also horizontally. And then you've got deficient here, so it's not gonna be a good site or candidate for implant placement because you don't have any bone at all. So we also this is something that you should look for while planning an implant in an implant site. And then implant dimensions. Before we continue here, do you have any questions so far? Because I think we might have some questions. Dr. Barakat?
I'm not seeing any questions on the chat.
There was one that did come up, and it was asking if we accept Romexis files, and I did answer it in the Q&A part. There is an integration tool we have with PlanMecca and 3 other CBCT companies, where the integration tool allows you to actually send your files directly from your CBCT and create the script, if you will, directly from there and send it over to 3DDX. Saves you time without the need for any planning software. And if you're interested in that, you can certainly just reach out and we can help you get that integration tool. I know that the group in North Carolina, the partners there, were really excited about getting that implemented into their team. And you can feel free to reach out to us and we'll be happy to help you with that, or to your representatives from your CBCT company. It's PlanMecca, Vatek, Jay Marita, and forgive me, I'm forgetting the last one. And there's one more that's coming online as well. But happy to help you with that as well.
That's awesome. I have a question, Dr. Hassan. When I do a lot of osteodensification, and I use a lot of the VersaVerse. How do you guys modify the surgical guide based on that?
So it depends whether you have the guided Versa kit. If you do, then we can actually provide you with a guide with a metal sleeve compatible with those components. So you can start with the pilot drill and then move along the diameter of the drills to densify the outline of the osteotomy as much as you can to make sure the implant is going to end up being stable. Or if you're planning on using those Versa drills to bump the sinus, for example, we also place the implants. But this is sometimes it's just a problem with clinicians who don't have the guided kit. So, but what we do basically is we plan the implant virtually to have its apex right at the floor of the sinus. And whether you have the Versa drills or just a regular guided kit, if you go all the way down, then the osteotomy would reach the floor of the sinus. So we plan the implant or the osteotomy, the bed of the osteotomy, to be shy, let's say 1 millimeter from the sinus, and then you'd have a direct or easier access to the floor of the sinus, whether you want to use osteotomes, or use the Versa drills freehand, but this is going to make it a lot easier for that procedure.
Got it. So basically you do that, get to the bottom of the sinus, and then you take out the surgical guide and do it the way you do it.
Yep. Or if you have the guided kit, then you can use the drills, the mark stops, of course, to just elevate the floor of the sinus and finally place in the implant.
Awesome. And say if I'm doing an anterior case and I want to expand the bone or osteodensify it, same thing. Initial positioning and then take out the surgical guide and do it manually or freehanded.
Yeah. So either you're using the Versa guided kit.
Yes. Yes. If you're not, then you're gonna have to do that. Yeah,
but in the end, both the guides, if you're either using the guided Versa or just the using a pilot drill, for example, to just drill the osteotomy and continue with the Versa freehand, you're going to have to remove the guide and place in the implant freehand, because with the Versa sleeve, you're not going to be able to place it through the guide.
Got it.
So you need to take, in the end, the guide out and place in the implant freehand.
Awesome. Thank you for that. Docs, any questions so far? All right. It's the 8-second rule, like our president Mark Soprano says. He waits 8 seconds. So yep. Nobody else says anything. Then we move on. There's a question from Dr. Vince Luton at second 7.5. Would you be able to remove the sleeves to use osteotomies with the guide in place?
I'm not really sure I understand. So
I think that's osteotomes.
Oh, okay.
Osteotomes, sorry, my bad. Yes.
That's okay, no worries.
Would you be able to remove the sleeves to use the osteotomes with the guide in place?
So if the question is to remove the sleeve from the guide, it's not going to be possible because we glued the sleeves inside the guide. So you'd have to take the whole guide out, use the osteotomes. And if you want to place in the implant, place in the guide back in, just to guide you to place the implant through the sleeve, you can do that. So you can actually remove the whole guide and then use the osteotomes and then place it back in if you want to place the implant through it. Or just continue freehand.
Dr. Benson, did that answer your question? Got it. Perfect.
Okay.
Thank you.
Okay, so let's move on to the next point. So here, implant dimensions, would the diameter or the length of the implant matter? Yes, it would. And how can I decide to use a wide implant or a long implant? So when we talk about implant dimensions, so the diameter, it depends on the tooth to be restored. So if I'm restoring a molar, a tooth that has been missing, then I would use a wide implant because the forces falling on that molar are going to be more. So I need an implant, a bigger implant, to withstand those forces. And if I'm placing an implant at, for example, site number 10 or 7, where the mesiodistal restorative space is not that much and the forces are not going to be that much, then I can use a 3.0 or a smaller implant. So it does depend on the implant site and the forces falling on that tooth to be restored. Another thing that will also help with or would allow you to just place or decide whether you want to place a long implant or not is immediate placement. So we see a lot of procedures where you take out a tooth, cure at the socket, and then place in an implant immediately. So what you want to look for here is to have the implant stable at the time of placement. So this here is an example of the same implant, but different length. So right here, this is the apex of the 10 millimeter implant. So it doesn't look like it's going to engage that much native bone apical to the socket. So then we move on to a longer implant, and using that longer implant, that would help you engage more of that bone and end up having a better stability for that implant. So this is also another factor where you have to choose to use a longer implant. But if you're going to be placing an implant in a site where the bone is virgin, then it does not matter to use a 13 or 15 millimeter implant, because that's not going to help with the osseointegration. Also, it only helps in the primary stability of the implant. So usually I wouldn't recommend place a long implant in a site where you're just placing an implant in just native bone or virgin bone. And that would also avoid having the overheating we talked about earlier. So using longer drills, that's going to be more difficult to just have irrigant reach all the way to the bed of the osteotomy, and that could lead to overheating. So I would only recommend using longer implants in sites where you have to place them immediately. So this is the rule of 3. So basically the number 3 or 3 millimeters we can see in planning, and all 3 on the left side. So either distance, biologic width, or emergence profile. So this is also stuff that we take into consideration when we plan, starting with the distance. So if it's only going to be a single implant on the left side here, you need to maintain at least 1.5 millimeters on each side, distally and mesially. So that, of course, would be a total of 3 millimeters. And on the right side, if you're placing multiple implants or more than one, then you need to make sure that 3 millimeters is the least distance you should have between those implants to prevent any vertical bone loss, and also maintain 1.5 millimeters on each side. So that would be 3 millimeters and 3 millimeters as well. And then, of course, to maintain the biologic width, especially for aesthetic zone, you would need to have 3 millimeters from the platform to the free gingival margin or the CAJ of the adjacent. And the emergence profile, so at least also 1.5 millimeters on the mesial and on the distal between the neck of the implant and the adjacent tooth to have a good emergence profile. Finally, of course, this is would be my personal recommendation, is to know the surgical kit you're going to be using. So know the components in the tray, know how to use them, because if you want to maybe just under prep the osteotomy if the bone is too soft, if you find out the bone is too soft, you can maybe decide to skip one drill, or you can use it just for the coronal third or middle third. Some kits have many components, so these components will help you to just make sure that the osteotomy is going to be good enough for the implant to be stable. So we usually see a lot of surgical kits that have very long drills. So you would know that you wouldn't be able to use those drills far back in the molar sites. So if you know that beforehand, then you would be able to at least figure out another way to place or have a guided template to use either those drills or other sets of drills that would not have that same problem. This is the last thing we're going to be talking about. And we can also wait maybe a couple of seconds if you have any questions.
I don't see any questions in the Q&A box.
Okay. So what are these challenges we usually see with computer-guided surgery? So we're going to be starting with either inadequate records, so records that are incomplete, insufficient restorative space, and I think we've mentioned them before, but we're going to be talking about that in more detail right now, and then possible discrepancies. So these are the challenges with computer-guided surgery in general. So the records, sometimes we have artifacts. These artifacts would be motion. So this is why we recommend it, or one of the instructions we usually would tell doctors to do is to make sure that the patient does not move while scanning, because that would create this motion artifact where you can see a mirror image of the patient's anatomy, make it really difficult to plan or to process or design a surgical guide. Metal artifacts, so this is basically when you have a lot of metal or titanium in the patient's arch, so whether they're implants, crowns, you usually have this this artifact, and it will make it really difficult to outline the dentition or the anatomy of the teeth, and it would also make it really difficult with the merging of the patient's model to the scan. Scattering, so this is also one of the artifacts we usually see. Beam hardening, and a limited field of view. So this would actually depend on the machine you're using. So some machines actually could provide you with choosing the field of view that you want to take or scan for that patient. If not, then if you have a machine that has or just usually scans with a smaller field of view, the problem would be is that, first of all, we're not going to have the complete or the entire arch recorded. So that's going to be a problem because, as mentioned before, it's really important to have the intraoral scan matched with all the dentition on the scan from one side to the other. The other problem will be not being able to record the occlusal anatomy, which we actually use to merge those scans together. So here, this is a screenshot of an example, of course, showing that the dentition or the coronal part of the tooth or the crown is not in the scan, so it wasn't recorded, and then you have this huge gap or space, and you cannot match the outline of the dentition in this intraoral scan with that scan. So this is actually one of the challenges we face when we receive those records. One more thing also is teeth separation. So we've mentioned also earlier that it's recommended to have the patient bite on cotton rolls. The reason why is that if the patient has crowns on the top and the bottom, having ththose teeth in central occlusion would just generate more artifacts, as you can see in the left-hand side, and would also make it difficult, even if the patient does not have any crowns, would make it really difficult to separate the arches in a 3D image and record or just check that occlusal anatomy of the dentition, and of course, accordingly, not being able to match the patient intraoral scan to the CBCT scan. Insufficient restorative space. So we also talked about this. If you have a tooth that has been missing for a while, so the distal teeth tend to just mesially drift. This is an example of a 5mm sleeve that actually is going to be in contact with the bicuspid mesial to it and the molar distal to it. We see that a lot, and the only thing we can do here, because the guide is never going to see it unless you relieve that contact. So if the contact is less than 1 millimeter, or actually it's not going to be that much, we would recommend on doing some either enamelplasty or crown reduction to the adjacent teeth to be able to fit the guide in without any problems or interference. But if it's too much, just like what we see in the scan or this the screenshot, then the only other solution would be just using a partial or partially guided surgical template. So what I would recommend here is, if the enamelplasty is going to be a lot, then to be able to seat the guide in, it only would seat if the sleeve is smaller, much smaller in size. So let's say a pilot sleeve. So the guide then would only provide you with guidance for the initial osteotomy, and then remove the guide, continue freehand, and then you can either just crown the teeth, or maybe just shave them a bit so you can have enough restorative space mesially to restore that implant. So this is also one of the things we see a lot of cases that we process. We have such a concern. And then possible discrepancy. So we need to understand, of course, the accepted or the anticipated discrepancy that might happen with guided approach. So that depends on a lot of factors. It depends on the length of the implant, the length of the drills you're going to be using, the height of the sleeve, the length of the sleeve, and the difference between the position of the sleeve and the bed of the osteotomy. So if you go longer and use long components or long drills, usually you'd have some discrepancies, basically at the apical third. So it's just always better to try to place short implants as much as possible, depending, of course, on the site and the restoration. But this is also just to understand that even with guided surgery, even if everything is done using the technology of the softwares and having the guide to help us with making sure everything is done according to plan, you should also just know that there is an anticipated discrepancy that might happen. So this here is a systematic review of 14 and 24 cases or studies. And that actually shows that you've got around 1.12 millimeters, and that's just an average amount at the entry point. So sometimes it depends again on the height of the sleeve and the length of the drill. So if you have the sleeve way up top or just high, then the point of entry would be just different, either mesial or distal. So they found out that it's around 1.12 millimeters at the entry point, and around 1.39 millimeters at the apical third. So this would be the average distance that the apical third of the osteotomy would either shift towards the left side or the right side, or even buccal or lingual. So this is just to explain that even with guided surgery, you should have or should anticipate that you might have some discrepancies. So even though it is guided and even though everything should be set according to the plan, and you might have some changes. So I think, yeah, this concludes the presentation today. We can still wait for some questions if you have any.
Thank you for an amazing presentation. This was very informative and
Sure.
and really to the point. I'm sure our doctors would love to try doing more guided surgery with 3D diagnostics. So and you know, as you mentioned, not every case has to be discussed with a dentist, but some cases are more complicated. Maybe initially when they start planning the cases.
Exactly.
They can schedule a call to get familiar with the process and everything. But you shared a lot of great tips and very informative. Every time I watch an expert in the implant dentistry field talk, I learn a lot. And it's really amazing what you guys have done and what you've presented.
Thank you.
Docs, I hope you enjoyed it as much as we all did. And please, we have time for questions, Q&A, so type it up or just text me on my phone or email me or anything. And we want to get these questions answered before Dr. Hassan is done. I know it's 1 a.m. your time right now.
It is, yeah.
So are you going straight to bed or are you...
No, no, I still have some stuff to do.
Please tell me you don't have another presentation after
no.
this one.
No, it's not another presentation. But yeah.
I think so. What's the next step moving forward from here?
I think Greg can answer that. Greg.
Yeah, absolutely. Appreciate all the attendees today and a couple of different options. I know the question as far as like integration tools and next steps and reaching out, you know, we created special pricing for everybody over at your group at Guardian. And so you have the ability to be able to take advantage of that, whether that's reaching out to your the regional folks that work with you, or you can reach out directly to me or to the team. The easiest way is to give us a call or just to send an email to info@3ddx.com. Here, I can actually let you see me as well. Now that Dr. Barakat showed his face, I mean, I feel like obligated that I should show mine.
No, you don't have to.
Oh, I can, because I'm not the host, yeah. So, you know, info@3ddx.com is an easy way. It's a great thing. Thank you for your comments, Dr. Grimes. He said, I've used 3DDX for years. They've reduced implant placement from 1.5 hours to 30 minutes. Great group. Thank you for that comment. Absolutely. You know, everything from singles all the way to full arch, you know, working all the way through. You know, we've really come up with some great pricing and, you know, it's not all about price. You know, what I've told dentists, I've been in the industry 16 years myself. The most expensive part of dentistry, especially in implant dentistry, is the doctor's time. And so, Dr. Grimes, you've really hit the nail on the head there. If you can save an hour of your time, imagine what you can do with that hour of productivity in your practices. You know, so that's something for sure. So yeah, just reach out. We're here for you. You know, from 8 a.m. Eastern to 8 p.m. Eastern. You know, we have a team that's here to help you out in every way possible and be able to service all of your needs. Everything from, we talked about surgical guides. We'll have, this is a series that we're doing. This was an intro. You got a little taste of some of the more advanced as well. And then we'll be doing one on multiples and some of the intricacies when you're doing multiple implants. And then we'll be doing one on full arch, specifically on full arch and our GFMR product. I know that Dr. Shadi talked a little bit about that product as well. So we'll get some more in-depth in that as well for you, and we'll be able to share that information. So we appreciate you being here tonight, and yeah, and understanding the platform that we don't open it up for people to be able to speak too much, because, you know, I know there's only 20 of you, but you can imagine when there's, you know, closer to 50 or 60, that can be a little bit much for us to handle. So
that's fantastic.
thank you so much, Dr. Barakat. Really appreciate you allowing us this platform to be able to share with your group and your team. We hope everybody enjoyed, and we'll have this on recording as well. So if there's pieces that you missed that you definitely want to be able to go back and reference, because there is a lot of information, we'll have that available for you as well.
Yeah, I was going to say, if you don't mind sharing that with me, so I can share it with our doctors who couldn't make it tonight. So I know some offices have late hours. I know some offices are Central Time. So would love to share that presentation with them. And as I get questions, I'll forward it to you guys. For our doctors and our partners, we have the special pricing with Chris Johnson and myself. So it's shared with all the RMs. Please just reach out directly to me or Chris if you have any questions, want more, or Greg, of course, if you have any questions or you want any follow-up after this presentation.
Yeah, and the great thing is too, if you go to 3ddx.com and you find our number and just call up, you know, the 844-866 number and just identify yourself as a Guardian partner, they will give you that pricing. They'll be able to identify you. We have the list of all Guardian partners, so we won't make you send you know, any kind of identification. We'll be able to find you in our system. So please feel free to just reach out directly as well. But of course, you know, I'm willing to help you, and Chris, you know, we were speaking earlier today, and Dr. Barakat. But of course, if you want to go direct to the source and give us a call directly, any one of our team, we have nearly 300 employees that are ready to serve you and help you in all of your needs. So thank you so much again, Dr. Barakat. And thank you, Dr. Shadi, for the presentation. That was fantastic.
Thank you.
It was very informative. I learned something every time I hear you present. And, you know, just as a layperson, I learned a lot. So thank you very much, everyone.
It was truly amazing, and looking forward to the next one. We'll plan it hopefully maybe September, October. What you and I, Greg, will circle back and look at the calendars and give the doctors the heads up, you know, early on, so they can plan their day.
Certainly, we'll absolutely do that. Thank you so much.
Thank you, everyone. Enjoy your evening.